Good afternoon, ladies and gentlemen. Welcome to the CHSRF On Call. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should select one of the tech support options at the bottom of your screen. I would now like to turn the meeting over to Mr. Stephen Samis, Vice President, Programs at CHSRF. Please go ahead, Mr. Samis.
Hello and welcome to CHSRF On Call, an interactive series by the Canadian Health Services Research Foundation. Our On Call brings together policymakers, healthcare executives, researchers, and others to be part of a dialogue about ways to improve healthcare for Canadians. We're pleased to now offer new and improved connectivity options for the whole audience on the call today, including new web streaming with integrated audio and video, allowing participants to listen through their computer speakers, as well as simultaneous interpretation for our French audience. As you heard, if at any time during our session you experience technical difficulties, please choose one of the tech support options at the bottom of your screen. So I'd like to welcome you to today's call, where we're exploring the issue of the fiscal sustainability of Canadian publicly funded healthcare systems. And we're really pleased that joining us today in studio is Don Drummond, Chair of the Commission on the Reform of Ontario Public Services, and also Livio DiMatteo, Professor of Economics at Lakehead University, is on the line as well. CHSRF commissioned a paper from Dr. DiMatteo in 2011 on the fiscal sustainability of Canadian publicly funded healthcare systems and the policy response to the fiscal gap. And both that paper and the commission paper led by Don Drummond are available on the On-Call website, which is www.chsrf.ca/oncall. Today's call will begin with brief presentations from each of our speakers, and then we'll open the lines up to a question and answer period when we'll take questions from the audience. Instructions for asking questions will be provided after we get through the two presentations. It's now my pleasure to hand the floor over to Dr. DiMatteo.
Thank you very much, Steve. Good afternoon, everyone. Bonjour et bon après-midi à tout le monde. What I would like to do is essentially overview the report that I did do for CHSRF and look at some of the general issues on the fiscal sustainability of healthcare in Canada. So the issue is quite simple. Fiscal sustainability has been a persistent policy issue for a good many years now. If you look at the most recent numbers by the CIHI, public sector health spending for 2011 is forecast at about $141 billion. The 2011 percentage increase is 3%. This is actually slightly down from the 6% increase in 2010. If you take the numbers and adjust them for inflation by converting them into $1997 and plot them, divide by population, you get real per capita public health care spending. And so the accompanying figure shows what the long-term trend in real per capita public health care spending has been from 1975 up to the present. If you look at the growth rates, real per capita government health spending in Canada rose at an average annual rate of 2.3%. This is faster than the growth rate of real per capita GDP or government revenues per capita. And that is, in essence, the crux of the sustainability issue. You have the spending growing faster than the resource base. If you look at the figure, you'll also notice that the growth in per capita spending appears in about three phases. From the period 1975 to 1990, you have a period of sustained increase. There is then a period of retrenchment from 1990 to 96, and then the period since a period of a resumption in the increase at actually a faster clip than what went on from 1975 to 2010. Moving to the next slide, the most important thing, I guess, is to actually try and get everybody on the same page as to what sustainability is. That, of course, is probably easier said than done. Sustainability of healthcare seems to mean many things to many people. From my perspective as an economist, I look at fiscal sustainability, but sustainability also involves the dimension of maintaining a quality healthcare system and, of course, access to people who need the care, as well as fair and equitable access to healthcare. Sustainable healthcare also refers to the affordability of care in conjunction with access, and that affordability of care also has to occur in the long term without unduly restricting other government program expenditures. So being able to pay for equitable access and access to quality services are also, of course, key components of sustainability. But in the end, as an economist, fiscal sustainability refers to the extent to which spending growth matches growth in the measures of a society's resource base. Ultimately, health spending cannot rise faster than the resource base. And so what fiscal sustainability means is having the money to pay for what you want to do at present. But of course, if you wish to be responsible, it also means having the money to do what you wish to do in the future. So you are making the system sustainable both at present, but also in terms of future requirements. How do you measure fiscal sustainability? Well, I have here a slide with some very basic measures that were then used to calculate sustainability. On the one hand, you can use some general macroeconomic indicators. I've labeled them as M1 and M2. They basically refer to the share of government spending taken up by health, as well as what the government health care expenditure to GDP ratio is. These are general indicators, and they've both been going up over time, but they're not the best indicators of sustainability because you really have to do them in reference to the resource base. I mean, in a sense, they can also reflect society's preferences or choices, as well as what the state of the economy might be. R1, R2, and R3 are indicators of affordability. What you can do is take the growth rate of real per capita government health spending, which I've called H, and compare that to the growth of real per capita provincial GDP, or R2, the growth rate of real per capita total provincial government revenues, or R3, the growth of real per capita federal cash transfers. These are all, in a sense, measures of the resource base. In addition, you might want to compare the growth of healthcare spending to other government spending. And so 3 other measures here. Excuse me. First, the growth of real per capita provincial government total spending, which is G1, the growth of real per capita provincial government program spending, G2, and finally, G3, the growth of real per capita provincial government expenditures net of health. Essentially, if H is greater than R, we have an issue with fiscal sustainability. If H is greater than R and H is greater than G, there's definitely a sustainability issue. If your healthcare spending is rising faster than your resource base and faster than other government spending, then of course something is out of whack. In terms of the historical evidence, these numbers are for the period 1975 to 2008. I've done that in an effort to avoid some of the fluctuations that have occurred with the Great Recession starting in 2009. But essentially, the numbers are fairly straightforward. The share of government health spending as a share of total government spending has been going up. It's been going up as a share of GDP. And if you look at the annual growth rates for the period 1976 to 2008, real per capita government health spending growing at 2.3% annually. If you look at the 3 resource-based measures or the other 3 measures of other government spending, healthcare spending has been growing faster than all of those, indicating a fiscal sustainability problem. If you break it up into time periods, the only period in which you could argue the healthcare system was sustainable, oddly enough, is the period from 1990 to 96. Based on these measures, per capita health spending actually shrank during this period as a result of the deficit reduction actions and grew slower than the resource revenue measures or the other government spending measures. But the period since 1996, healthcare spending has resumed its upward trajectory at a much faster clip at 3.1%, and again, that is greater than the other resource measures. The study also constructed some future resource scenarios, 5 scenarios altogether. They are detailed in the paper. 3 of them are regression-based, in which you then estimate coefficients and then make some assumptions about how the variables will behave. And the last 2, 4 and 5, are simple growth extrapolation approaches under assorted scenarios. So one scenario is business as usual, assuming things pretty much behave the way they have from 1975 to 2008. Scenario 2 is a low economic growth, and scenario 3 is low economic growth plus more rapid aging, and similar assumptions are made in 4 and 5. So let me just show you very quickly the forecast estimates in the study for Canada as a whole. This is real per capita public sector healthcare spending in $2010 for Canada, starting off in 2008 at just over $3,800 per capita. And if you look at the 5 scenarios, under each of these scenarios, spending is going to at least double, if not more than double, depending on whether you have scenario 1 or 5 or one of the others. It goes from a low of 6,552 under scenario 3 to a high of $8,798 under scenario 5. The next slide, based on the assumptions, also looks at healthcare spending as a share of GDP. And so we start off in 1975, 2010, and then the 5 scenarios is where you would be by 2035. And again, you go from a low in this slide of about 9.5% of GDP, of public healthcare spending as a share of GDP, to a high of 13.4 under the 5th scenario, which is the most extreme scenario. That assumes, of course, that spending will continue to grow in an extrapolation forecast at the rate of the 1998 to 2008 period, but with lower economic growth. And then finally, compound annual growth rates for real per capita public healthcare spending and government revenues under the 5 scenarios are presented in this next slide. And again, even under the scenarios that forecast somewhat lower growth in healthcare spending, by the definition of fiscal sustainability used in the study, the system is still inherently unsustainable. Real per capita healthcare spending tends to grow faster than government revenues in all of the scenarios. It's just a question of how large the gap is, depending on the scenario that you've used. In terms of fiscal implications, scenario 5 is the most extreme. The extrapolation assumption assumes that health spending trends for the 96 to 2008 period will continue, but with lower economic growth. Under this scenario, per capita government health spending in Canada by 2035 would hit $8,798, and the public expenditure to GDP ratio would hit 13.4%. Just to put that into context, this projected increase is equivalent to an increase in public spending today of about $2,797 per capita and would require a 15% increase in per capita revenues to fund. So, to wrap it all up, what might the broad directions for solutions to the fiscal sustainability healthcare issue be? And I guess I have 3 broad categories here in order to sort of help frame the discussion. First, you can reduce the growth rate of expenditures. Second, you could increase the growth rate of revenues, or you could do some combination of both. In terms of reducing the growth rate of expenditures, I mean, your decision, in a sense, falls into one of 2 categories. Would you happen to use the sword or the scalpel, for lack of a better term? The sword approach would involve broad budget cuts across the board, with healthcare providers and institutions left to absorb the blow and deal with the shortfalls as best they can. The scalpel approach involves targeted reductions with reforms in service delivery and financing and other types of reforms. In a sense, the scalpel approach is where you'd want to go. The holy grail of fiscal sustainability, I guess, for public health care would be reforms that somehow bend the cost curve down and improve both the quantity and quality of services in healthcare via transformative change. In terms of increasing the growth rate of revenues, that could either involve increasing tax revenues or reducing other public expenditures in order to release the resources to provide more revenue for healthcare. Again, the issue there, how much more are people willing to pay in terms of taxes? Per capita government revenues have been rising over the last 10 to 15 years, even with tax reductions. The question is, do you wish to increase the rates, and if the public would settle for that? And in terms of reducing other spending, well, what would you reduce? What choices are people and politicians willing to make? In the end, I think this entire sustainability issue is going to be quite complex, and there will be no easy solution. Success will require persistence on the part of governments, and ultimately there's going to have to be evidence-based decision-making and political decisions that direct where the sustainability issue is going to be resolved. So I'm certainly looking forward to the rest of the session, to Don Drummond's presentation, and, of course, the questions. Thank you very much for your attention.
Hi, Don Drummond here. Good day to everybody. So here's your double dose of economics. Sorry about that, but I guess you saw that in the billing, so you signed up anyhow. So I'm a little less intrigued by this notion of sustainability than some others might be. It's a very slippery concept. What does it actually mean? Because I think you need to bring the political part into what we used to call political economy. There's never been a poll done anywhere in Canada that hasn't had health as the number one concern of people, and obviously that's logical, as everybody realizes who has suffered from poor health. Nothing else really matters if you don't have your health. So in a democratic society, it's not surprising, alarming, or particularly concerning if you do see the most important thing to people rising as a share of its overall revenue base. So for the sake of some numbers onto this, let's just suppose the future real growth rate of Canada was 2%, and 2% inflation being 4% increases in nominal income. That would tend, without revenue tax rates changing, to give you revenue growth of about 4% a year. Now, a pure sustainability model, that would suggest that healthcare has to increase 4%, but with healthcare roughly 50% of provincial budgets, healthcare could actually increase by 6% if everything else could increase by only 2%. That's probably pushing it to the outside margin, but that certainly is conceivable. That might reflect the voting preferences of the public. There are some opportunities as well to do that. There is certainly low growth, and in some provinces declines in the school-age population, so you can squeeze out to some degree of education. So it's a little bit hard to nail down more precisely what's sustainable and what's not sustainable. I find the more intriguing question is, why would you want to sustain the current healthcare system? Because I don't think it's so great. That would be a revelation to Canadians, and of course, in trying to make it greater, your first obstacle is that Canadians don't really seem to appreciate what we actually have in our healthcare system. First of all, they don't think it's particularly expensive. Why do they not think it's expensive? It's because it is not as expensive as the U.S. system, and we're trained since birth to compare ourselves uniquely to the United States. They spend over 17% of their gross domestic product on healthcare, and we spend less than 12%. Therefore, in Canadian terms, we're cheap. But if we put aside the United States for a moment, we're in a very small cluster of countries as the second most expensive healthcare system in the industrialized world. We look at the quality of our healthcare system in any meaningful weighted measure, we're about in the middle of the pack. So we're at the expensive end of the pack in terms of expenditures, and we're about in the middle of the pack in terms of results. And there's some aspects where we do really poorly. For example, we have the highest rate of hospitalization with adults with diabetes. We have much longer waiting times for general and family practitioners than virtually every other developed country, and we're literally off the scale for waiting times for specialists relative to everybody else. So I think a more intriguing question is whether the money has been used very wisely. If we're going to take our almost 12% of our gross domestic product, should we accept that as a reasonable base, and should we just naively fall into a trap that might continue to grow at 5 or 6%? What is it getting us for that money? And I would argue that historically it hasn't got us as much as we should. Therefore, we shouldn't continue that pattern. The other intriguing thing about our healthcare system is the public thinks it is a public healthcare system, and in fact, in the CBC poll in 2010, we overwhelmingly voted that the single factor that identifies us as a nation is our public healthcare system. Again, why do we think it's a public healthcare system? Because 70% of our healthcare is in the public domain. In Canada, it's only 46.5% in the United States. Therefore, they are private and we are public. But again, if we set aside the United States, we are one of the lowest coverages of public healthcare in the developed world. Most of the other countries in the high 70s and low 80s. We also have a very odd structure in which all the primary care is in the public, less than half of pharmaceuticals is in the public, and less than 10% of everything else, including mental health, which is the fastest growing issue in the healthcare field, is in the public domain. Most other countries, if it's not purely at health, they at least have a quasi-public-private insurance system. In Canada, in the CMA's poll of 2011, they found that 15% of Canadians had not filled a prescription in the preceding 12 months due to financial needs. I don't think Canadians would recognize that system. So I think the focus needs to be making our healthcare system more efficient and more effective, regardless of what the growth rates are and what regard that. We can do better than that, and we can simultaneously do better on the financial side and improve the quality of the results. We should not be the longest for wait times than any other country. We should not be having the highest rate of hospitalization for adults with diabetes, and probably not by coincidence, we have the lowest rate of adults with diabetes taking the 3 standard annual tests. And just simple things come to mind on that. When I turn on my car immediately tells me how many kilometers I have to go before I have an oil change. As I get close to that date, I get an email from my dealership I have to change my car. The people with diabetes get no notice. Nobody's tracking whether they're changing it or not. There's no monitoring of that kind of situation. And it's a little bit odd why it would be more sophisticated in dealing with a car than we were dealing with people's lives. Interesting for anybody in British Columbia, you've got the smart card coming your way, finally a breakthrough, but I always think that if I was ever hit by a car lying in a ditch in Ontario and a paramedic came up to me, if I could say something, I would say, take my credit card, don't touch my OHIP card, because my OHIP card has absolutely no information other than my number, so I guess they could figure out how to bill me afterwards, but aside from that, everything about my life is on a chip on my credit card. Why wouldn't we have that in that space? We have a staggering number of prescriptions on average given to Canadians. Why? Mostly because they've come from multiple of doctors, many times some prescribed to offset the side effects of others, multitudes of pharmacies that are not tracking it. We found when we did the report in Ontario a fascinating statistic that 1% of the Ontario population, being only 13,000 people, account for almost half of all the hospital spending and 34% of all healthcare spending. Everything in life is skewed. That's never going to be a proportional relationship. But again, you get this dual sense of dynamic. The lack of coordination of the care of those people is obviously deteriorating the quality of their life. It's a congestive heart patient who is released without electronic discharge notice from their hospital, so nobody knows they're out. The physician doesn't know. The Community Care Association doesn't know. No nurse is visiting within 48 hours. They have a slight problem. They're right back in the hospital. In any province across the country right now, you will have 10 or 15% of the hospital beds occupied by people who should not be in the hospital. Probably many of them should not even have been in the hospital in the initial stage because we still have a system that's hospital-centric. Why would we want to draw people who have some particular ailment into an environment where there's a lot of other sick people and give them sources of infection, give them the lowest rate of satisfaction? And even stepping back even further than that, basic description of our system is one built for acute care, which is exactly what the doctor ordered in the 50s and 60s and 70s when the system was created. We're a chronic care model right now, and we're very, very slowly moving towards that. We're operating on the edges of chronic care from a model that's acute, built around an acute care. So things need to change, and my premise is that they will change. And I regret to say, from an economic and fiscal perspective, they will change because the fiscal crunch is not going to go away. And this will be the big distinction between the future we're facing right now and the 1990s. In the 1990s, all governments in Canada applied fiscal restraint to healthcare. Some applied some significant reforms, but they basically abandoned them after somewhere between 2 to 4 years because the economy continued to grow fairly strongly, the revenue growth was there, they got back to budget balance, and they could abandon the healthcare reforms. They didn't need to keep in that fiscal discipline mode. I don't think that's going to be the case going forward. Remember, every country in the world now simultaneously applying fiscal restraint, although Canada did it alone. We don't have $1 at 62 cents the way we did in the 1990s. We're not going to face a strong growth in the U.S. economy, so our growth prospects for Canada are more modest, hence the revenue prospects are more modest, and so hence while there will be some reprieve from the fiscal restraint, most of the provinces, maybe with the exception of Alberta and Saskatchewan implementing right now, the reprieve will take a while, and it'll be much more modest. So I think we're finally going to see, and it's going to be fairly long drawn off, a fairly holistic approach to healthcare, not just solely driven by getting the numbers down in the spending, because the lesson we should have learned from the 1990s, if you do something that creates a perception of deterioration of the quality, the public will not allow you to persist. So we have to simultaneously working on improving the healthcare system, and we can still do that, have our cake and eat it too, and we can still do that with getting the growth rate down. So I will end there. Thank you very much.
Thank you very much, both Livio and Don. Excellent. We hope that we're actually going to open things up now to questions from the audience. There are two ways you can pose your questions today. You can do that online, or you can do that via the phone. And we will wait to see questions coming through. In the interim, I have a question to start us off. This one's for Livio. In terms of forecasting estimates for the provinces and territories up to 2035, are there any regions of the country or provinces in the country, territories that are showing early signs of performing either particularly well or that are still really struggling from your perspective in terms of sustainability? And are there specific factors that can explain these differences?
Thank you, Steve. There are regional differences. There are some large differences in spending across the provinces. If you look at per capita government spending, the biggest spenders right now are probably Newfoundland, Saskatchewan, and Alberta. The lowest spenders per capita are actually Ontario, BC, and Quebec. And going forward, the provinces in the east that are basically lower economic growth, more rapidly aging populations, are going to see more fiscal pressure moving ahead over the next 10 to 15 years than, say, Alberta or Saskatchewan, which have relatively younger populations and faster-growing economies. So your sustainability, in a macro sense, is tied to your economic circumstances and your demographics.
Great. Thank you. Dawn, a question for you. Which area of healthcare expenditures, pharmaceuticals, physician payments, et cetera, is likely to see the most reframing over the next little while in order to maintain or to rein in healthcare spending and deal with this fiscal issue?
I hate to say it, but the answer has to be all of them, because I don't think you can cherry pick that. Certainly the most obvious answer would be the two areas that happen to in the fact would be pharmaceuticals and mental health. Pharmaceuticals have cooled off in most of the provinces in the last couple of years for two reasons.
First of all, we have not had an outburst of new drugs coming on the market, and there isn't an awful lot in the immediate pipeline, but who knows, that could resume its force in 5 or 10 years. Mental health is probably the most worrying aspect, and simply because we have no idea what to do about it. We've had a number of commissions suggesting some changes, and we typically wait until the problem has become exacerbated. And, of course, many of the people with mental health issues in Canada have ended up in the justice system where they're getting no treatment whatsoever. That cost is probably going to mushroom quite a little bit. But I would say, even though, for example, hospital budgets have not been rising all that fast in recent years, they'll have to actually be compressed quite a bit further. Physician payments in many provinces have certainly been rising quite quickly. I think you can certainly see the agreement was just struck with British Columbia, 0.5%, the Ontario government going for flat. You'll see a period of flattening out on that, and it'll probably rise less modestly as well. But let's face it, when you spend $192 billion, which Canada did on healthcare in 2011, if you're going to get that cost curve down, it's pretty much going to have to come in all aspects of it. And probably in unconventional ways. One thing we didn't raise, we'll just put it onto the table. I find that it's interesting when a country will think out of the box. So there's a presumption in Canada with the aging of the population, we need to build hundreds of thousands of long-term care bed facilities. And in fact, in the David Walker report last summer in Ontario, he calculated that to meet the current and the needs over the next 10 years of the elderly population, we would need to build 220,000 long-term care beds. I think everybody agrees that the country that does the best job of looking after the elderly population is Denmark, and Denmark has not built a single long-term care bed since 1987. And just so they never lost the discipline, they actually passed a law in the late 1990s preventing themselves from doing it. And it forced them to create an efficient nexus between their community care and their home care. And again, it plays back to this dual symptoms that I was talking about, where that lowered their costs because it's much cheaper to look after the people at home than it is in a facility, but also increased their satisfaction because almost everybody, if they can do it, would prefer to stay in their home. So they will, if you have trouble getting out of your bathtub in Denmark, somebody will come out almost immediately and put in a bar to help you get out. They'll put a ramp on your front door. They'll send meals. They'll cut lawns, and that gets the cost down and the satisfaction up. Excellent. Thank you. Again, just a reminder that you can submit questions both electronically and by telephone. For English and French participants on the call today, you can submit your questions electronically using the questions box located at the bottom left of your screen. And for English participants not connected via a computer, you can ask your question verbally by pressing *1 on your touch-tone phone. And when asking a question, we'd ask that you please identify to whom you'd like the question to be addressed, and please try to ask only one question at a time. Another question for you, Dawn. You've talked throughout your talk about many of the ways in which we can achieve efficiencies in the healthcare system and actually have better quality, better care for Canadians. And we know many of the things that we need to do in order to do that, and you've enumerated some of them. So why is it so difficult to have these things happen? And including things like the introduction of new technologies, there's new disease management processes, and some of these things we've just known for a long time, like how to reform primary health care in ways that other countries do. Why is it taking so long?
Well, I think this goes back to the very first thing I said, that there's never been a poll done in Canada that has not had the result that Canadians say that healthcare is the number one issue, the number one concern that they have, and it has made political leaders hypersensitive to doing anything, and that has been reflected by bureaucracies that haven't been terribly proactive as well. As the late Joyce Smallwood is alleged to have said, I've never said anything about healthcare that hasn't cost me votes, and hence I think that's probably an accurate statement, and hence you don't tend to say anything about it. We have not historically had stakeholders play a large role and a public role and a public information and a public conditioning role. Take, for example, my observation that Canadians think we have the best healthcare system in the world, where we definitively do not. Canadians think we have a cheap healthcare system, where we definitively not. No one has ventured to tell them any differently. Governments will not tell them. None of the stakeholders have ever done that. So I think we need to satisfy a couple of conditions before we get that reform. We need the stakeholders to rise and put forward their own proposals, hopefully generating some kind of consensus amongst themselves. It doesn't have to be airtight. They need to step out of their traditional roles and communicate and condition to the public to that. And if and when that is done, you will find the politicians peer out of their bunker and move forward. How many times have we read a statement, usually by an editorial writer, lamenting the fact we cannot have an adult conversation about healthcare in Canada, but implicit in their statement is a relatively juvenile sentiment that the adult conversation must be led by governments. We have to recognize that's just not going to happen. It's not realistic. It has to come from other parties in it, and the government will follow in the wake of it. On the technology side, I think we finally have probably learned a lesson that you don't go in huge, massive one-shot efforts, like the initial objective of e-health to do it all and all together is probably not the right way. But then the current situation in most of the provinces of building up in pieces, which may not be compatible at the end of it, is not the right either. So we have to be it's sort of a paint by number. We have to figure out all the little boxes and what colors goes in the boxes, and maybe only paint all the blues initially. But we need to figure that part about it, and it is slowly coming, but I emphasize on the slowing. But again, it will come with greater force if we're in this continued aspect of some kind of fiscal discipline, because that always seems to be the catalyst for fundamental reform. Unfortunately, when a better world, one would think one wakes up and decides just to make a better healthcare system, but unfortunately we don't tend to do that if the revenues are coming in to allow us to spend a lot of money.
Yeah, very true. Thank you. We have a question here, and I'm not sure. I think maybe Dawn, but Livio, if you're interested in answering this one as well, I invite you to come in on it. The question is that Canada Health InfoWay was initially set up to address some of the needs for patient information sharing. However, the disinvestment of the federal government has led to a patchwork of attempts by the provinces which have not been able to set up systems akin to the one in British Columbia. Do you think the federal government should assert a leadership role so that all Canadians benefit from a common level of healthcare services? So, a couple of things in there. Both the whole issue of the electronic health record and the attempts by InfoWay to get that going, as well as the federal government's role in healthcare. Maybe, Don, if you take the first part of that.
Yeah, so, okay, let's just get to the heart of fiscal federalism. Yes, obviously, yes, they should. Yes, they should play a role in other things. I think one of the oddities we have in Canada right now is 6 provinces have created health quality councils. There are various different names, but they're doing sort of what NICE does in the United Kingdom. Why in the world do we need 6? They're basically looking at the same things with the same mandates. In a smarter federal structure, we would probably have one of these things serving all of the interests, but we don't. The federal government is not going to play a bigger role, at least not the current government, and let's get over it. That's the way it is. We're at an odd shape in Canada's constitution and our fiscal federalism structure, in which historically anything in Canada that's been national has by definition been federal. And at the current moment, the federal government is not going to play that role. Does that not mean that there cannot be anything national? I don't see why it doesn't. I really don't understand why the provinces don't get together and do more things themselves. They've actually even set up a political apparatus to do that. They came together in tainted blood. 18 months ago, they said they were going to build up a national agency to establish a price for pharmaceuticals across the country, a great thought. Unfortunately, they're not doing much on the since, but why don't they do more of that? And healthcare is not unique. I was telling before we went on the air my story on labor market information, where the provinces don't get together and start out labor information. The councils and ministers of education are more active, but they don't do an awful lot. The provinces themselves could absolutely play that role and coordinate the aspects of info way. You saw a letter, a very interesting letter sent by Premier McGuinty recently to the provinces, asking them, inviting them, almost urging them to play a more activist role. You also have the task force being led by Premier Giz and Premier Brad Wall right now, looking at some of the aspects of efficiency. I just thank God, about time we're kind of getting this stuff. So I think a lot more can be done by that. And yeah, we can chip away at the federal government. We can criticize and maybe make life bad, but they're not going to do it. It's not going to come in the next little while. But let's go on. The provinces can make things go ahead.
Thank you. Livio, do you have a comment on that?
Well, I broadly agree with Don. I guess the point is, though, that health is a provincial responsibility, and ultimately a common info way across the provinces is going to require an awful lot of coordination. There's not really a health system in Canada. There's 10 provincial systems and the territorial system. So setting up common information networks does require a fair degree of cooperation amongst the provinces, and that's been difficult to achieve up to this point. It's easy to say the provinces should get together, but there really is not a formal mechanism for them to do it. That's where the federal government should be taking the role in bringing them together and providing the framework in which they can work together better.
Thank you. Don, just to go back to that, how do you, given the lack perhaps of a mechanism, a formal mechanism to bring the provinces together around these things, and yet the urgent need for provinces to get together and collaborate and find efficiencies, and there are many ways in which they can do it. How do we get around that?
Well, self-interest alone should do it. So I got to tell you, if I was a health minister in a province and I was contemplating doing something that might upset my electorate, I would sure like to have some other provinces doing the same thing. That would just give me an awful lot of comfort. And we got some precedences here. It's really fascinating to follow the rollout of Ontario's attack, if you want to put it, on the generic drug price in 2010. And you're seeing it being implemented across the country slowly. That's the kind of thing you're looking for. And so as somebody from Ontario's perspective, as somebody in Alberta, Saskatchewan, Newfoundland does something else that they think is a great idea, you're going to see them copying that. But why don't they get together and do it more simultaneously? So again, it's self-interest. Yes, Alberta certainly thinks it's in a unique position and will stay in a unique position for a long time. Maybe Saskatchewan does it, but you know what? I would be really cautious even on that point. On that, oil prices were well over $100 a month ago. They're at $82 today. Most people thought natural gas prices were going to go way over $10 a BCF a couple of years ago. They've been hanging at $2 a BCF right now. Things can change awfully quickly. So I think that impetus for finding efficiency gains and quality improvements is a common interest across the provinces. They don't have to act as I said. I mean, even in Ontario, 95% of an individual's health needs are met within one of the 14 LHINs, never mind even province-wise. And so I'm from British Columbia originally, but I'm not going to be going out there and having medical health needs. Let's not exaggerate the need. Most of the provinces can look after most of their needs themselves. But where there is a common interest, why wouldn't they come to get it? And why don't we shed this big brother attitude that we can't come together unless the federal government convenes us? Meet yourselves.
Mm-hmm. Yeah, good point. And we do have the Council of the Federation now, which is creating an opportunity to do that. I have a question here for Livio. It's been shown that health spending has not crowded out spending in other government programs during the last 20 years. If you see sustainability within this lens, there's no historical evidence that health spending is unsustainable. The richer we become, the more we spend on certain goods and services, including health. That's not a problem if it's a society's choice. What's your perspective on this?
Well, in a broad sense, you'd have to agree. I mean, in the end, your healthcare system is as sustainable as you want it to be. If a society collectively decides it wants to spend 20% of its GDP on health, I mean, who are we to argue against that? But the question is, ultimately, you still have to pay for it. You can't spend 20% of your GDP on health, but then also insist on 20% of your GDP on everything else. I mean, in the end, you do have to make some choices. I think in the end, it's political in the sense that society has to decide where it wants to invest its resources. And as long as people want to spend more on health, I suppose you could do that, but it does mean less for other sectors. I don't know if I fully agree with the fact that health spending hasn't crowded out other spending. I mean, as a share of government budgets, health spending has grown over the last 20 years. Now, you could argue that might be because revenue hasn't augmented, you could have spent more, but again, that requires higher taxes, and the public is a bit schizophrenic. On the one hand, they'd like more spent on public goods. On the other hand, they've also welcomed tax reductions. So you really can't have it both ways.
I'm going to chip in on that. Let's not go back 20 years. Let's go back to 1998, because 1998 is an interesting year, because it's when the federal government and most of the provinces got back to balanced budget, and it was the beginning of letting it rip on all spending, not just healthcare spending. So every province in the federal government over that time period until the recession hit increased their total spending, excluding interest on the public debt, but everything they spend on education and health and the whole thing combined, somewhere around 6%. Some of them are a little bit faster than that, some a little bit slower than that, but the averages were right around 6%, with a fairly high concentration around that, including the federal government. Healthcare was just a bit above that. So it's actually true that healthcare didn't crowd out stuff. So, for example, in Ontario, education increased by almost 6%, but almost everything increased by almost 6%. But here we come the point that in Livio's scenarios going forward, and the one I gave, the dynamic changes in the future. The reason they did that, and the reason they increased spending by 6%, is because the revenues were coming in at a very rapid pace. But if I'm right, and the revenue growth in most of the provinces would only be about 4%, and I'll add in Livio's answer about the Atlantic provinces being particularly strained. You take a province like New Brunswick or Nova Scotia, where the labor force is actually declining, their sustainable revenue growth might only be 2 or 3%. Well, then you can't have healthcare increasing 6 or 7%, because you would have to squeeze out everything else so extraordinarily hard. And let's face it, I mean, we are in a knowledge-based era. We do need to spend some money on education, K-12 and post-15. And it turns out, while people really like their healthcare, they also want police protection and parks and the likes as well. So the person who posed the question is absolutely right. I'm not so sure of the 20 years, because it definitely has gone up over the 20-year period, but there was a period for the 10 years after they got back to budget, you really couldn't say healthcare was, because they showered money on everything. And I just simply don't think that we should realistically assume that governments continue to do that in the future.
Could I jump in with an extra point there?
Absolutely.
The other point about the period since 1998 is it has been rather unique. You had balanced budgets and very low interest rates, and in a sense there was a fiscal dividend from tackling the deficit, and a lot of that has been applied mainly to health, but also to other program spending, but health has been able to thrive in part because of that. I mean, I don't think you can continue to assume that interest rates are going to stay as low as they are, and deficits have opened up again over the last couple of years.
Right. Yeah. Here's another question for either of you, actually. The question is, can the concept of fiscal discipline be accompanied by legislation? That is, could government set health spending targets over time, like the Bank of Canada does for inflation, especially since the federal government has set targets for its health transfers to the provinces? Would this aid spending discipline? Well, actually, we've got empirical record on that. Absolutely not. They've been a total failure in every country. It's a typical thing in politics and policy. You do what you want to do, and if you don't want to do it, you don't do it, and a little piece of legislation is not going to stand in your way. So the most recent one we'll hear about it is the U.S. government keeps running into its legislated debt ceiling. And what fascinates me is every time they hit it, we're inundated with newspaper articles, the entire U.S. government is going to close down. I say, well, wait a minute. They've run into the ceiling 26 times since 1980, and they've changed it 26 times. They will change it. I sense a model here. We used to have in the 1980s, it started off with Graham, then it was Grand Rudman, then it was Grand Rudman Hollings. They were running at the same times as Crosby, Stills, Nash and Young. They never got up to the fourth name, but they were sort of singing the same tune. Every piece of legislation they put forward, every time they ran afoul of it, they just changed it. Let's remember in the European Union, let's go right to the heart of the matter. The original principle was you could not join the EU if you had a deficit bigger than 3% of your GDP and a debt ratio higher than 60%. Well, excuse me, like virtually everybody's kicked out. Did they kick them out? No. Why bother? Just change the rule. So
You know, the federal government, when they went to the balanced budget and got there very quickly, they didn't do the legislation. They wanted to do it. The public egged them on. And if they had gone off track and they had a piece of legislation, they would have just changed it. So we're fortunately in Canada, we got a democracy, and governments will reflect the will of the people, and the people get exercised about it, as they were for a brief period in the 1990s. Governments will do it. And it was fascinating from depending on which province you were in, Saskatchewan earlier, and some of them came into it later, but there was a period of about 4 years in Canada in 1990 that you had a political imperative to be tackling your deficit, and you were going to be booted out of office. But also, the final thing I'll say on that is everybody thinks that fiscal discipline is a political loser. Every government in the 1990s that ran a strict political regime, from Romanow to Klein to Harris to McKenna and New Brunswick and to Chrétien and the federal government, got elected with a big majority at the end of the exercise. So much of it being a political killer.
Livio, do you have a comment on that?
Well, when it comes to politics, rules are made to be broken.
Short but sweet answer there. This one's for Don. The question is, you mentioned that home care is a policy response to the aging population. And, however, research done by Dr. Nora Keating has demonstrated that home care in Canada is often inadequate, with Canada's seniors, quote, falling through the cracks, end quote. So is fiscal sustainability really achieved through placing the elder care burden, on individuals, and more specifically women, as they're typically the informal elder caregiver?
Well, I guess I recoil in the way the question is put, in the sense of putting the burden on them, because I don't look at that. My entire thesis and everything in the healthcare is driven about the quality of the care, but to be able to deliver that is, in Livio's terms, on a sustainable basis. I'm not about just to dump the expenses on someone else, and I'll go back to we're in a democratic society. You should pay attention to what people want, and people overwhelmingly want to stay in their home if they can. I mean, ultimately, if they're not able to look after themselves with a reasonable amount of care, they can't, and they probably don't want to, but they do. And the person who is 85 and has lived at home and wants to live at home and finds that they can't get up the front stairs anymore does not want to be carted off to somewhere else. They would rather have somebody put a ramp up to their front stairs. And if they needed assistance with the meals, so they can't cut their lawns, they would rather have somebody cut their lawn. And, you know, the cold-hearted, I would say no-hearted economist, would say, yeah, plus, that's a heck of a lot cheaper. You can build an awful lot of ramps, and you can have a lot of people cutting someone else's lawns, as you see in the Veterans Administration operations in both Canada and the United States, and save a heck of a lot of money and deliver a better quality outcome. Would you want to just pass a burden on to the elderly person that they may or may not, most likely will not be absorbed? Absolutely not. But I don't look at it that way. And obviously you have to have some kind of income support that would go along with that way and facilitate it. But you've got a lot of money to play with. You know, that's the common denominator in this. You know, I've talked about my 1% of the population in Ontario accounting for 49% of the hospital spending. You know, we've done the calculations. There are people who are regular visits at homeless-based healthcare clinics, and their average costs for healthcare, social assistance payments, and the justice system are around $200,000 a year. And you can imagine the alternatives and the possibilities of better health care for those people, earlier alternatives. And it's the same thing for the elderly. It's very expensive to look after them in the highly institutional range. You can do an awful lot to support them to have a happy home life and save a heck of a lot of money.
Thank you. And Livio, to what extent did those kinds of policy choices, those kinds of alternate arrangements of care, factor into or influence the kinds of scenarios that you modeled out?
Well, my scenarios were from a more aggregate perspective. I mean, there's a sort of a macro approach to sustainability and the micro approach, which involves a lot of program innovation. Those types of things have not been factored into the macro scenarios. So I'd have to say that I sort of didn't dig right down into each individual category. I think that's important. I guess the only other thing I want to add is all these notions of sort of reforms, transformative change. I do think that they're important, but we also have to be careful in considering them because, in a sense, the changes themselves aren't costless. There's going to be a lot of transactions and coordinations costs. You're going to have to spend money, in a sense, to implement a lot of these reforms. So On the one hand, it's important to be optimistic and try and bring about these changes. On the other hand, I guess my concern that might sort of stymie change and bring us back to business as usual is that so much has to be done that you could end up biting off more than you can chew by trying to implement reforms in a whole bunch of sectors. I think governments are going to have to, based on evidence, prioritize and decide which 2 or 3 major innovations or reforms they're going to make. Are they going to reform primary care first or home care? Are they going to implement information technology? But you're going to have to sort of use an evidence-based approach where you decide where the benefits are going to be best, prioritize, and tackle them in a sequential way. I mean, if you open up on many fronts, I think you're going to quickly get bogged down in a lot of opposition, and the government will lose their focus in terms of implementing the reforms.
So what this whole notion calls for is sharp differentiation within healthcare budgets. So sorry to keep giving the examples of Ontario, but of course, having done the Ontario Commission, I'm kind of steeped in their numbers. In their budget, they said healthcare for the next 5 years to grow at 2.1%, but there will be virtually no component of healthcare should grow at 2.1%. Clearly, community care and home care should grow faster than that, and hospitals will have to grow a lot less rapidly than that. Interestingly enough, in the details behind the Ontario 2011 budget was exactly the opposite. They actually had the hospital budget going faster than the community care budget. That would have made absolutely no sense whatsoever. But it's a tough decision, and people get upset. The hospitals will be, well, I was going to say the hospitals will be upset, but that's kind of interesting because when we were doing the commission, actually the first person to drew my attention to the fact that the 2011 budget implicitly had the hospital budget growing faster than community care was the head of the Ontario Health Association, and he told me it was absolutely a ludicrous proposition that the hospital budget should clearly grow less rapidly, and I had to kind of make sure I understood that you were saying that your group that you represent should get less budget increase, and he said absolutely. So there we go. There's the kind of stakeholder thinking we need.
Well, at the Ontario Association of Health Centres conference last week in Toronto, Minister Matthews said that hospital funding will be held at 0% increases, and there will be 4% increases in the community budgets over every year for the next 3 years. So it's an interesting point. I have a question for you here, Don. The question is, frontline workers often have excellent ideas for reform. Are they being consulted in a serious and ongoing way?
I don't think anybody's really been consulted. In fact, I'm in a fascinating period right now because I've been asked by many associations all over the place, in pharmacies, drug companies, hospitals, physicians, family health teams, they want to engage with me to give me their ideas, and I have to be open with them and say that's a dead end because I'm not involved in the process anymore. They want to engage with somebody. They've got a reaction to the recommendations I made or recommendations making in another province. They've got their own ideas, and there doesn't seem to be an outlet for them to do it. It was always a fascinating thing I had in the 11 years I was at the TD Bank, because they actively did not want the people doing the administrative, the back office, or even the front line innovating. And you kind of get that because you can imagine if you make a mistake, you could bankrupt a whole organization. But on the other hand, you find that the truly innovative ideas of running anything almost always come from the inside. One of the intriguing studies that came to my attention while I was doing the Ontario Commission report was on a healthcare center in Seattle, and they had done a survey of everybody who worked in the healthcare sector, from the surgeons to the people who were cleaning the floors, and they found that 1/3 of their time was spent looking for things. And I found that was fascinating when you talk about the efficiency argument. So that was a surgeon couldn't find the right implement when they're in the middle of doing a surgery, and it was the person cleaning the floors that could find the mop, but they couldn't find the pail or they couldn't find the soap. They would have an idea. The people doing that work would have the idea of how they wanted to structure that and how they could save that efficiency time. Somebody sitting in a provincial capital in a health ministry would have no idea how to set that up. So we do need to hear their ideas.
Thank you. I guess this is kind of an overall question for you, Don. I mean, your report had how many recommendations?
366, 105 of them in the healthcare sector.
105 in healthcare.
But who's counting?
Right, well,
it kind of blurs together by that point.
So this is a tough question then in light of 105 healthcare-related questions, because this questioner says, what 2 or 3 reforms would you prioritize?
Yeah, see, I refuse to play that game. In fact, I have a sentence in there that this is not a smorgasbord for you to pick and choose the tasty morsels. You have to take them all. And if there's one that you're not going to eat, you have to substitute it with something else. I was not clever enough to figure out how to get out of Ontario's fiscal box with throwing away a whole bunch of my recommendations. And so, for example, in the education field, the first one I said, you cannot afford to proceed with full-day kindergarten at this time. And they said, we are going to proceed. And I said, okay, now you're $1.5 billion off the target you gave me. You had better come up with something else to do it. And the same thing on the healthcare stuff. I like to think in a systems approach for efficiency, they hung together and they needed it for that sense. I'm sure you could drop some of them, but I don't think you can drop very many of them without replacing it with something else. And that's probably where I disagree somewhat with Livio. I think there's so much that needs to be changed, and maybe you do need to sequence it. But I think also the lesson we learned from governments in the 1990s, where they were successful on the fiscal front, they actually did strike out on a broad fashion. And for political reasons, that's necessary, because if you pick only a subset of areas to tackle at a time, those who are being addressed at first feel hard done by. They feel you're being very unfair to them, and they get their back up. It's probably not the first order of the ideal situation, but having everybody equally ticked off at you is not a bad place to be, as long as there's no one more ticked off than somebody else. So I think I would urge in the healthcare sector, they really do need to pick up either all 105 as specified or some reasonable facsimile of each one of them. You can't pick and choose.
Thank you. Interesting. So it'd be interesting to be looking at those 105 recommendations and see where they cohere and how they fit together, particularly as we move forward in health policy and sustainability conversations. I think finally, because you mentioned this, Don, in the course of your talk about the use of technology, diagnostic imaging, etc., and how recently the Ontario government is tackling some of the fee schedules around some of these specialties. The question here is, what is your opinion on the rapid use of technology, such as diagnostic imaging tests, in increasing our healthcare expenditures? So,
there's no doubt that's a fact. I mean, your typical thing, and what's implicit as Livio was going through there, you pick up the population, you add that the aging, you look at the inflation factor, and then you got your usage or your intensity, how often we use the healthcare system, and one of the main drivers of that is technology. It's a wonderful thing for somebody who's having trouble walking around that there are knee and hip replacements, and with a lag we're coming along with ankle replacements, and they improve the quality of life, but they're very expensive, and there will be other things that will improve our quality of life are very expensive. You obviously don't want to hold things back from that. Well, you do have to be careful, though, on the use of the technology that, is effective and efficient. We do a lot of diagnostic tests, and we've had a lot of profile on some of them recently. Vitamin C testing in Ontario, which was delisted and was not found useful. One of the CHI chapters featured 3 practices that they didn't find there was any useful benefit from, and one was arthroscopic knee surgery. We have osteoarthritis that just simply postponed it. I always call this the Dr. House phenomenon, because I think that Dr. House, before his show ended, probably went through about $10 million of cost of diagnostics on a patient every single week. And it kind of leaves you, if you've got a hangnail wanting to have a CT scan and an MRI, and why not? Dr. House ordered it. These things aren't necessary. A lot of cases, a simple X-ray is all you really need. But if you're going to have the X-ray, make sure it's portable. I kind of wanted to have an X-ray transferred from Ottawa to Toronto. I didn't really need it, but I shouldn't say this because I probably wasted some public expenditure, but I wanted to see how it worked or didn't work. It brought me to tears. I actually ended up going back to the hospital and getting it on a physical copy of the CD and taking the CD in hand myself. There didn't seem to be any way that we could transmit it elsewhere. At least that's better. At least we could get it. Otherwise, I'd be going with a negative, trying to check the negative into the luggage or something. We're moving ahead, but we could do an awful lot faster. And I said, just coming back to the BC and the smart card, you're a paramedic, you're coming across a person, they're unconscious. Wouldn't you want to know what they're allergic to, what their blood type is, what kind of medication? This is all possible. It's all on my credit card. Like all the equivalent of that is on my credit card, and that's existed for 20 years. Surely we can give it a I don't know anybody who hasn't had an experience close or near to they go in an elderly person's medical chest and there's 15 prescription bottles in there. They take them to a single physician and they find out like 80 of them were prescribed to offset the subsets of the other 7. I mean, I'm exaggerating a bit. Why wouldn't we have a record of that somebody could compare? You don't combine these two things. The scientific test says if you're taking more than 8 prescriptions, you're almost 100% chance of an adverse reaction, but nobody knows, and no one's comparing that stuff. So again, you get that thing. I'm sorry, the broken record. You get that thing. Things that increase the cost also quite often deteriorate the quality of the person's life. That's not a good thing to be taking that many drugs.
Well, it's a great way to end this call, because we are out of time, but it's to really think about this issue of sustainability and efficiency in healthcare, but also always thinking about it in terms of what's the best quality healthcare that we can provide, and what do patients really need and want when they're in the system. So I would like to, I'm sorry that we aren't able to get to other questions that we had on today's call. Thank you for sending those in. We will get those questions to the speakers. I also like to thank both of our speakers very much for an excellent session today, really interesting. And we could be spending a lot more than an hour discussing the really important issues that you've both raised today. To those on the call, we thank you for joining in today. We hope you will join us again in 2 weeks' time for our final session of the on-call season, when we discuss optimizing the roles of nurses to improve efficiency, so picking up on some of the issues that we've talked about today. Next time we'll have Gina Brown, Professor of Nursing at McMaster University, and Scott Robertson, Chief Nursing Officer in the Northwest Territories, on the line with us. And of course, please stay tuned for On Call to return in September for our 6th season, actually. Registration details and more information on future on-calls and the full lineup can be found at www.chsrfoncall.ca/on-call. We also invite you to sign up for our electronic newsletter at CHSRF to stay up to date on this and all other activities. And again, by going to the On-Call website, you'll be able to find both of these really interesting papers that have informed our discussion today. Thank you very much for being on today's call. Have a nice day.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.